sound. All right, so I just want to thank everyone for joining us today. This is I think we want to go back to the top of the present. There we go. This is the third webinar in our Implementation Sharing webinar program for the Agency for Healthcare Research and Quality Pressure Ulcer Prevention Program. So thank you again for everyone who was able to join us today. So to start things off, we'll just do a little bit of housekeeping, brief update on our upcoming webinar, and then we're going to go straight into the special presentation that we have today, putting the nutrition guidelines into practice for pressure injury prevention by Dr. Mary Litchford. We'll have a period of time for question and discussion and wrap up. In terms of housekeeping, just as a reminder to everyone, when we get to the discussion section, we hope that you'll participate, and there are several ways you can do that. One is to click on the little hand icon and let us know that you actually have a question or comment. You can also use the chat panel. I'd like to just remind everyone, if you use the chat panel, you want to make sure that that little send to box says all participants. So you'll need to use the little drop down menu and scroll down to find all participants. That way everyone can see your comment and or question. We will be muting all the lines during the presentation portion, but when we open the lines, we ask that you keep your phone muted if you have, so that we keep that background noise to a minimum. In terms of updates from the AHRQ team, I just want to let everyone know that we will be going back to our hospital updates next month, and this will conclude the implementation updates, and we will hear from both Fort Washington and Broward. So we're looking forward to hearing about their implementation activities. So let me just briefly introduce Dr. Litchford. Dr. Litchford is an acclaimed speaker, author, medical legal expert, and a consultant to healthcare providers. She received her PhD in human nutrition from the University of North Carolina, Greensboro. Professional careers included clinical practice, university teaching, and business consulting. She is the president of Case Software and Books, a professional and educational resource company. Also a member of the Academy of Nutrition and Dietetics and the Academy of Nutrition, and was a participant on the Dietetics Evidence Analysis Work Group on wound care. She's a member of the Board of Directors of National Pressure Ulcer Advisory Panel and currently serves as the Vice President. So it's my pleasure to turn the webinar presentation over to Dr. Litchford.
Well, thank you very much. It's my pleasure to come to this webinar to talk about one of my favorite topics, and that is putting the nutrition guidelines into practice for pressure injury prevention. Now, as I said injury, did the nomenclature change? In April of 2016, the National Pressure Ulcer Advisory Panel held a consensus conference. It was on staging, and at that meeting, it was announced that the word ulcer was being changed to the word injury, because pressure injuries result in ulcers. But for cracked skin, you can have an injury without an ulcer, so it's stage 1. There's much more to the story than that. There'll be a manuscript out to provide you the science behind all of the changes that have been implemented. So we're talking about pressure injuries today. So what are learning objectives going to be today? Well, I'm going to talk about the steps to prepare for dialogue with the hospital medical staff on order writing privileges for the registered dietitian nutritionist. In this webinar that I did for you, there were many questions about how to implement this. And so I do have a section today on that. So we're going to discuss strategies to identify new admissions who are at risk of malnutrition and pressure injuries, and to examine the role of nutrition in reducing readmission rates. And then lastly, to apply nutrition guidelines for prevention of pressure injuries using a case study approach. We're going to our webinar today with a visualization exercise. I want you to visualize your work setting, and I want you to think about what kinds of things could we change to optimize the care that we're providing for our patients. It may be something small, it may be something big. I'm giving you some suggestions just to get you thinking. What you have in mind may not be on my list, but let's just look at the list. Perhaps the way that nursing, medicine, and nutrition care services communicate with each other. We paper records. Some of you don't even remember those days before we had electronic records. But back in the old days, we had handwritten notes in medical records. And so now that we use electronic records, do we communicate any better? Obstacles. Are there obstacles in getting messages from one person to the other? And one thing about that system you'd like to change. What about the process of writing diet orders and gene orders? Or perhaps the tools used to screen new admissions for malnutrition. The way nurses use the nutrition screening tools, or the way nutrition screening tool scores are disseminated to other healthcare professionals. The tool completed and the score and it's on the medical record, but not disseminated perhaps to other people. And the way that decisions are made on which certified foods and oral nutritional supplements are stocked, or perhaps even tube feedings are stocked. So formulary decisions. Now, that's a short list. But we're discussing the process change to optimize nutrition care for your patients and for prevention of pressure injuries. I want you to keep this thought in the back of your mind of what kinds of things would I like to change in my setting would help me be more successful in this. If you have a handout, you may have already checked off some of these items or just perhaps made a mental note of them. And we'll talk about them again at the end. I'm going to start with our discussion on order privileges for the RDN. RDN is the preferred credential from the Academy of Nutrition and Dietetics. RD is the older credential. They are equivalent. The registered dietitian, RDN, registered dietitian nutritionist. The order privileges for the RDN were in the Federal Register on May 12, 2014, so that's a little over 2 years ago, and they were effective July 11, 2014. And this is what the first sentence in the final rule says: hospital registered dietitian privileges. We are permitting registered dietitians and other clinically qualified nutrition professionals to be privileged to order patient diets under the hospital conditions of participation. Is a link. The link takes you to the Federal Register for the rules and regulations. Talk about how you would develop a global action plan for ordering privileges for the RDN. So is do your homework. I'm a college professor, and I remember students saying to me, "Oh, I just cannot wait to get out of school. I will never have to do homework again." Well, that is not true. There is homework to do in implementing a plan for ordering privileges for the RDN. You need to read the rules and regs and to craft an action plan. But be sure you've done your homework and know the ins and outs of those rules before you start this, before you implement your plan. Is begin with the end in mind. Know the purpose of the rule of the final rule. And I'm not going to tell you what that is. You read those regs, do your homework, and know the purpose of the final rule, because you always want to come back to What is the purpose of the rule? Why are we doing this? The third component is to know the key provisions and identify the key players, and I've listed some of those on the slide. Step is to let the money do the talking. That the focus is on cost, reducing cost, and benefits to the patients. Now, once you've got the decision makers attention about ordering diets and changing diets, what about some other order writing privileges that are components of the nutrition assessment process? So labs or diagnostic tests that are specific to the nutrition diagnoses. This is an opportunity to ask for those as well. Here are other resources that will be helpful for you. The rules and regulations are called the Medicare and Medicaid programs, regulatory provisions to promote program efficiency, transparency, and burden reduction. So that tells you a little bit about what the purpose is. Again, the link that was on the slide 2 slides ago, that's not a different link. Anatomy of Nutrition and Dietetics has 2 tip sheets. One, hospital regulation, ordering privileges for the RDN, and the second is implementation steps. And the link is below on the slide as well. Are very useful resources for you. Again, start with rules and regulations, go through those, understand what's a document, and then the tip sheets will be more useful to you from the Academy of Nutrition and Dietetics. So study and look at putting the guidelines for nutrition into practice. Now, when I say global guidelines, I'm referring to 2014 international guidelines that were developed by the National Pressure Ulcer Advisory Panel, the European Pressure Advisory Panel, and the Pan-Pacific Pressure Injury Alliance. Our case named Jed. Jed is a 68-year-old retired tobacco farmer. He was with his son. He was found unresponsive in a smoke-filled room. It appears that he set his hair on fire with a cigarette. Admitted to the hospital with smoke inhalation. He had a history of hypertension, prediabetes, emphysema, atherosclerosis, mild cognitive impairment. He's a smoker. He has a history of alcohol abuse. He had pneumonia 4 weeks ago, although that is resolved. 70 inches tall and weighs 147 pounds. So his BMI is a 21, so lower end of normal. And according to the primary care physician's weight records, he's lost 8 pounds in the last 3 months. And as he's on furosemide, avastin, and albuterol, his reports that he eats all foods, but he prefers ground meats and well-cooked veggies. So he likes soft foods, and appetite is very good. What else we can find in the medical record? Here's some vitals and some labs that I've pulled out. His blood pressure was 100/73, and his heart rate was 108. His sodium was 147, so that's going to be elevated, and chloride was at 106. Both of those are milliequivalents per liter. His glucose was at 130 milligrams per deciliter. That's elevated, but it is not a fasting glucose. His AC was 7.2, which is elevated. And creatinine are 36 and 1.4, and those are milligrams per deciliter. If we look at liver function test, all 3 of those are elevated as well, the ALP, the AST, and the ALT, and those are all in units. His hematocrit are 16 and 48%, and MCV is 97. Human is 3 grams per deciliter, and a prealbumin was not ordered. So the screening tools that nursing completed at the time of admission. His Braden risk score for pressure ulcer risk was 15. And so that means he's at risk, but not particularly high risk. If you use the nutrition subscore, then gave Jed a 3. That's adequate. The nurse also did the mini nutritional assessment, came up with a score of 7. So let's look at what she identified or he identified on that form. M&A, and this is just one of several valid nutrition screening tools, but this is the one I chose to use for this presentation. The first question deals with, has food intake declined over the past 3 months due to a loss of appetite, digestive problems, chewing, or swallowing difficulties? Jed's son reported no decrease in food intake, so that's going to be a score of 2. What about weight loss during the last 3 months? Well, Jed's lost 8 pounds, according to the records, so that would give him a score of 0. Jed is up and around, and so he gets a score of 2. Next question is, has suffered psychological stress or acute disease in the past 3 months? The answer is yes, so that would be a score of 0 because he had the pneumonia a month ago. In neuropsychological problems, he has a score of 1 because he has mild cognitive impairment. The donation was that he had some mild dementia. And then his BMI based on his height was 21, and so that gives him a score of 2. So our total score is 7. So he comes up malnourished, but right at the top of that score range. So let's go back and see what we have here. He started on IV fluids when he was admitted to the hospital, and the doctor ordered a regular diet with thin liquids. So we can assume the dietitian does not have order writing privileges. Else we can find out about Jed's first day in the hospital. Mood, he's confused, he's combative, and he's irritable. At night, he's only wanting coffee and sandwiches and sweets. He refused breakfast, so they come in really early in the day, and he was able to eat something, but he refused until later in the day. He's just too tired to eat, and he wants to go home, and he wants to know where his son is. The does a nutrition assessment, and that includes a nutrition-focused physical assessment. Some of the dietitian's observations. The dietitian does an oral exam and notes that Jed's dentures are ill-fitting. Now, prior to doing an oral exam, the dietitian could have heard the denture clicking in the background. Sometimes when dentures don't fit well, if you're observant enough, you can hear them clicking because they're loose. But also once the person opens their mouth and you do an oral exam, it's pretty obvious if the dentures are ill-fitting because the person has lost weight over time. What was noted was moderate muscle wasting in the upper and lower body. So it might be muscle wasting in the triceps, the biceps, it could be the deltoids, it could be the pectoral muscles. In terms of lower body, either the quadriceps or gastrocnemius muscle, that would be the calf, quadriceps would be the thigh. Moderate muscle wasting in the face, that would be the temporalis muscle and the masseter muscle. Those are your muscles of mastication for chewing. Also some moderate muscle wasting in the hands. So that would be the interosseous and the thenar. That's going to affect his ability to open things and possibly to use utensils and to cut foods. The notes that the skin is very dry and the lips are peeling. The eyes appear light yellow. And according to nursing, there's a decreased urine output, and the color of the urine is amber. And the plan is for more labs to be ordered. Now think about GED's nutrition risk factors. Based on what we know about GED and the scores on its screening tools, are there any nutrition risk indicators that increases risk for malnutrition and pressure injuries? That in order to be at risk for a pressure injury from a nutrition standpoint, the person must be at risk for malnutrition or have malnutrition. So would you say, probably not, that the data is inconclusive? That bread and sub score was a 3, that's adequate. But the nutrition assessment was a 7. Well, that's malnourished. So inconclusive data, or you could say yes. That would be the answer, and this is why. He's had a significant weight loss of about 5% in 90 days with a BMI in normal range. Now, he's had an acute illness, but he had this steady, insidious weight loss. His focused physical assessment identified moderate muscle wasting in 4 or more sites. Respiratory diagnosis associated with increased energy requirements meets the criteria for a nutrition diagnosis of malnutrition. His labs are consistent with dehydration. He had the low blood pressure but the elevated heart rate, as well as the elevated serum sodium, BUN, and H&H. If you did have prediabetes and the glucose was fasting, that may be also a red flag in terms of the dehydration. Because remember, when you take the water out, all the components in the blood are going to be more concentrated, so everything increases. You have an albumin, but that doesn't tell us anything about his protein status. It only reflects his inflammatory stress, and it may be due to the episode that he's had with the smoke inhalation. It may be related to chronic conditions. Now, glucose, as I said, was non-fasting, so that doesn't really tell us very much. But the A1C is troubling because it does reflect poor blood glucose control, maybe related to the stress of the recent pneumonia, or it may be that he has full-blown diabetes and not aware of it at this point. Doing our nutrition assessment, we want to use our nutrition care process, and the next step would be to write a PES statement with full nutrition diagnoses. Our PES stands for problem, etiology, and signs and symptoms. These are just selection of possible PES statements, not an exhaustive list. We'll give you some ideas. First, suboptimal energy and protein intake related to smoke inhalation, confusion, and emotional state, evidenced by moderate muscle wasting in 4 or more sites. Looking at historical information as well as in the hospital. Increased energy requirements related to respiratory illness and recent smoke inhalation is evidenced by a 5% weight loss in 90 days. Suboptimal water intake related to recent illness and hospitalization is evidenced by abnormal labs, consistent with dehydration, and I've noted which ones, and physical findings of very dry skin and cracked, peeling lips. A couple others that are possibilities would be chewing difficulty related to ill-fitting dentures, and wasting of muscles of mastication, that's going to be temporalis and the masseter muscle, as evidenced by nutrition-focused physical findings of muscle wasting in face, keen sound of loose dentures, and report from patient that dentures didn't fit properly. If you did an oral assessment and noted the dentures were ill-fitting, that could be included there as well. And then malnutrition indicators related to multiple chronic conditions and ill-fitting dentures as evidenced by moderate muscle wasting in 4+ sites and a 5% weight loss in 90 days. these are just some examples of PES statements that you could use for a nutrition diagnosis. Our assessment of nutrition-related pressure injury risk. Based on global guidelines for prevention and treatment of pressure injuries is consuming sufficient energy and protein to reduce risk for pressure injury during hospitalization. Well, choices, probably not. And yes, he's eating a sufficient amount that is within the current recommendations. There is probably not. Let's look at a little bit more here. In the global guidelines for prevention and treatment of pressure injuries and evidence-based recommendations for older adults, would you recommend a change in his diet order? Now, diet order is a regular diet with thin liquids. Not, since he's going home soon, or yes. Well, from Jed's history that eats a soft diet at home, he has ill-fitting dentures, the answer to that would be yes, we need to change the diet. Now, the global guidelines estimate his protein and energy requirements. The protein recommendation is 1.25 to 1.5 grams per kilogram of actual body weight. So we would use his admission weight, which was 147 pounds. That's a range of 84 to 101 grams of protein. If we look at the energy requirements based on guidelines, it would be a range of 30 to 35 calories per kilogram of actual body weight, or you could use indirect calorimetry if that was available to you. Use 30 to 35 calories per kilo gives us a range of about 2,000 calories to 2,350 calories per day. Last question was, on our previous slide, was do you think he is consuming between 84 to 101 grams of protein and between 2,000 and 2,350 calories? My answer to that is probably not. Now, in order to meet Jed's protein and energy requirements, we can do this with a lot of different approaches with diet. We can use supplements, we can use fortified foods, and we can do med passes. We can do a lot of different things in order to meet those numbers. But optimize tissue synthesis. Because what you want to do is to maintain the skin and to have the body repair itself from whatever the reason is for the hospitalization. And so you optimize tissue synthesis. If you look at literature in sarcopenia, what we have learned is that to optimize tissue synthesis, have 30 grams of protein at 3 to 4 meals per day optimizes that process. What's critical about 30 grams of protein? Well, a couple of things. Number one is it's got to be high-quality protein. So either from whole muscle meat, chicken, beef, chicken, pork, seafood, eggs or dairy products, or a complete source of dietary protein that's a protein supplement. There are different oral nutritional supplements that are protein supplements on the market. And to blend to a whole animal product for tissue synthesis, there's a little bit more than just the 30 grams of protein, because the amino acid that triggers tissue synthesis, or the mTOR pathway, is leucine. Leucine is one of the branched chain amino acids, and according to the studies, you need at least 2.5 grams of leucine at a meal with 30 grams of protein. And so typically, if you're a whey protein isolate, for example, for 30 grams of protein, you have more than 2.5 grams of leucine. But it's not true for some of your other products, such as your soy products, your collagen products, your hemp products. They be complete protein, but they don't have the very high level of leucine that you see in the whey products. and see in whole foods that are animal sources of protein. So you be sure that you are serving 30 grams of protein at a meal. And I've given you some examples of ways to do this with food. These are not complete menus. I only included on the slides ideas in terms of the protein-rich foods. And if you notice, the one at the bottom is a protein isolate powder that you would add to milk. And you can see the range from 29 to 32 grams of protein. Now, in the second example, I've got a slice of whole wheat bread for 3 grams of protein. Typically, a person has some other food items for breakfast other than what's on the slide, so they're probably getting a little bit more protein from some of the other items that they'll be consuming at that meal. And then some ideas for lunch and dinner. I think as Americans, we do a good job at getting 30 grams of protein midday and in the evening, but breakfast is the meal that seems to be the hardest to get people to consume 30 grams of protein. Now, I look at his total amount of protein per day as anywhere from maybe 90 to 100 grams. 30 grams per day would be 90. If we went to our full 100, then we'd have about 10 grams of protein left. And so let's look at some ideas. 10 grams of protein. Now, for Jed, he has a diagnosis of prediabetes, and he may benefit from having the HS snack that's high in protein. What happens to Jed? He's charged to home on a regular diet, so nothing was changed about his diet. The dietitian might have requested a change or recommended a change, but without order writing privileges, change was not implemented in Jed's case. His charge weight was 140 pounds. The nurse they've scheduled a home care nurse to come twice a week to assess his status, kind of follow up with Jed. So he goes home, and at home, the home care nurse arrives, but Jesus to let him in. He says he's doing just fine, and he doesn't need a nurse to check on him. Home care nurse suspects that Jed is intoxicated. Sound like things are going well at home? Does it sound that Jed is meeting his nutrient needs to prevent skin injury? Well, he certainly was discharged from the hospital with intact skin, but things are a little different at home. Day 3, Jed still feels like he's getting better each day, and he's eating about 2 meals a day. But most of his day watching TV and drinking beer and sitting in his recliner. He started to complain that his bed is uncomfortable and decides to sleep in his recliner. On day 5, the notices that there's a change in status, that Jed is confused at times, and sometimes his speech is garbled, and he's complaining of pain in his lower back, and he won't get that recliner, he's sleeping in it, and his son says that Jed's food intake has been good, but now he's sipping on liquids on day 5. Well, his son is concerned enough that it is getting worse that he calls 911, and Jed readmitted to the hospital. Initial assessment by the nurse, whose skin assessment, they divided per injury, a 3.6 to 4.2 centimeter open area on the sacrum, covered with slough and eschar. About some points to ponder. I want you to think about Jed's nutrition status at the time of discharge to home. His order was a regular diet with thin liquids. His weight was 155 pounds, in the months prior to the acute episode. So in many days prior to this first hospitalization, not the pneumonia one, but with the smoke inhalation, he had lost 5% or 8 pounds. And while in hospital, he lost another 7 pounds. So that's going to be another 5% weight loss. So he's lost a total of 15 pounds in 3 to 4 months. Now, it is true that these weights were done on different scales, and we have from the primary care physician's office, we've got weight at admission and at discharge. Those may not be on the same scale either, but we know that Jed has lost weight through the last 90 days, and that's his intent. So, first question, was Jed's pressure injury avoidable? So this webinar series is about preventing skin injuries. Would the outcome have been different if Jed had received a different diet and more nutrition support during hospitalization? Did Jed know the importance of nutrition? Did his son know the importance of nutrition and the risk that Jed was having a problem with skin breakdown and pressure injuries? And outcomes have been different if the RDN had authority to change Jed's diet on day 1 of his initial hospitalization. The RDN identified a number of issues with his diet on day 1. Would they have been different if the RDN had had the authority to make that change immediately, or to have ordered the original diet to begin with, and probably to order some supplements based on Jed's preferences? Jed's readmission. His injury is covered with slough and eschar, so that means it's unstageable according to the 2016 staging consensus. Once slough and eschar are removed, it's most likely going to be a stage 3 or 4 pressure injury. Instead of seeing Roman numerals with the stages, we've gone to Arabic numerals, and so you will see these Arabic 1 through 4 for the stages of pressure injuries. New problems. He's having some difficulties with speech and may require tube feeding or some oral nutritional supplements. Would recommend an immune modulating supplement. This is from the global guidelines in the protein intake section. And the nomenclature is 2014, so it's our old nomenclature. Supplement with high protein, arginine, and micronutrients for individuals with a pressure ulcer category or stage 3 or 4, or multiple pressure ulcers when nutritional requirements cannot be met with traditional high-calorie and protein supplements. This was a new recommendation in the 2014 guidelines. And because Jed has a stage 3 or a stage 4 injury, then this would certainly be considered as the best choice to put healing if required, especially to go to a tube feeding. But just to be sure those nutrient requirements are met, let's look at the study, the Oligo element trial. This was one of several trials that were used to support this recommendation. There were 2 groups. There was an intervention group that received one product, and a control group received a separate product. If you'll notice, the total protein is the same. The intervention group received arginine, and the control group did not, and a higher dose of zinc, copper, vitamin C, and vitamin E compared to the control group. And they received these supplements daily. And our findings, about 70% in the intervention formula group had 40% or greater reduction in pressure injury size compared to 54% in the control. So what's special about these products? Well, the efficacy of these nutrients in wound healing is likely synergistic, is what the authors concluded, because there's no evidence to support an independent effect when given alone. So if you just gave the arginine or you just gave more zinc, we didn't see kind of effect. But when the nutrients were all together, plus meeting the energy and protein requirements, that's that synergistic effect. Nutritional intervention may help when added to optimize local wound care for the treatment of pressure injuries in malnourished patients. That was the conclusion of the authors in this particular study. Why aren't these products being ordered? Well, the reason is cost. And based on how things are set up in your organization, cost may be of great concern. And so, is nutrition support for the prevention of pressure injuries cost effective? Well, this is a study that came out about a month ago in the Advances in Skin Wound Care, so that would be in the middle of 2016. It was a year-long study in Australia comparing standard care with nutrition support care. Now, the difference between the standard care and the nutrition support care was that the patient received more patient education, nutritional setting, and consumption of high-protein supplements. And findings were that the nutrition support care provided substantial cost savings, and that the probability of nutrition support being cost-effective was 87%. The valuable article to share with the decision makers in your hospital is cost-effectiveness of products, and especially for the prevention of pressure injuries, is a topic of discussion among your colleagues. This will be a very interesting study. It is a number of citations. There's some other studies that the authors cite that provide supportive information as well, but this was the newest one that I found. Now, NPUAP pressure injury prevention points provides prevention points for all aspects of care, but these are the ones from nutrition. Number one is to consider that hospitalized patients are going to be at risk for undernutrition or malnutrition just from their illness or because they've been NPO for diagnostic testing. People come to us malnourished, but others end up that way as a result of what happens to them due to illness, surgery, injury, whatever. It is to use a valid and reliable screening tool to determine risk of malnutrition. The mini nutrition assessment is just one example. There are several. It's important to refer all individuals at risk for pressure injury from malnutrition to a registered dietitian nutritionist. To assist the individual at meal times to increase oral intake. To all individuals at risk for pressure injury to consume adequate fluids and a balanced diet. Ned's lab suggested that he was dehydrated upon admission, and dehydration increases the risk for skin breakdown because the skin can become more fragile. Weight changes over time. Assess adequacy of oral, enteral, and parenteral intake, and provide nutritional supplements either between meals and with oral medications unless contraindicated. The rest of the mention points are at the link noted on the slide. Other sources are the clinical practice guidelines. This is what the global guidelines look like, and you can order these from NPUAP.org right here. And there are some other resources for pressure injuries as well. NPUAP has updated the pressure injury stages, and that's the link. on your slide, and then the prevention points are here. And then there are also some new staging illustrations, and these have all been put up on the website in the last month or so since the conference. Think back to Hippocrates. We talked about him in our first webinar. He said that was credited for saying that healing is a matter of time, but sometimes also a matter of opportunity. So are you taking advantage of all of those nutrition opportunities that present every day in your hospital? Let's think back to our visualization exercise at the beginning of our webinar. What would you see changed? It may be something on this list, and it may be something that you've added to the list. The challenge to you is to think about how can we optimize nutrition care for the prevention of pressure injuries. And in order to optimize what we're doing will most likely require some changes. And so what are some changes that would positively improve our outcomes with our patients? Minutes for questions. Jill, do you have some questions for me?
Let's open it up to the group real quick, and thank you so much for that great presentation, really informative. And Deidre, I'll ask you to go ahead and be unmuting folks that folks can ask any questions that they might have. But yeah, I mean, let me ask just a couple of questions to sort of get it started. So is there any benefit at all to using the oral supplement products that contain HMB?
Well, HMB stands for beta-hydroxybutyrate, and so why we call it HMB. HMB is a metabolite of leucine, and leucine is that essential amino acid that is you get up to a certain level that sets off the mTOR pathway for tissue synthesis. So about 5% of leucine is metabolized into HMB, so it takes about 20 grams of leucine to produce 1 gram of HMB. So what we have seen in the studies is that HMB supplementation is associated with increased lean body mass, so you're gaining lean body mass without gaining weight or gaining fat. And it's associated with improved physical function and assisting in wound healing. Now, there's some products on the market that do contain HMB. Some of them are amino acid therapy, so they have some amino acids added to them. Others are oral nutritional supplements that have them added to it. A look at the fitness products for bodybuilders and elite athletes. These products contain HMB. There's no evidence that it is a negative. I don't know of any tube feedings that include it, but that is another tool that's out there, or another product that will help increase lean body mass and may be involved in assisting with wound healing. HMB was not identified as a recommendation in the global guidelines in 2014.
Okay. So if a hospital service prefers to use food rather than supplements, and that may be the case here, and certainly I encourage some of the hospitals to chime in here. Is it realistic that you can actually meet the energy and protein needs of a patient just from the foods that would be on the menu?
That's a good question, and quite challenging when you're looking at 1.5 grams of protein per kilo of body weight, 35 calories per kilo of body weight. Some of the foods may be need to be fortified, so things need added to them. And there are some fortified foods that are on the market that you can purchase. So I think it's important that we always start with food first, because that's realistic. What people are going to do once they get home is to consume regular foods, and usually that's people's preference. If focusing on food first and what is reasonable for them to consume. So the volume of the food is to meet these requirements is such that it becomes limiting. And so at least at one meal, having some type of a supplement may be the way that you can reach that 30 grams of protein. So remember that when a person's in negative energy balance, which they're not consuming enough energy, their protein requirements are higher. So they're higher than 1.5 grams per kilo. And that's because the body's using protein for energy instead of for tissue synthesis. So when you have a person on a very low intake, they're going to need even more protein. So it's very important that you're realistic about what is this person willing to do, what are they able to do in terms of consumption. They're in the hospital as well as for discharge planning when they go home.
Okay. So are there any questions from the hospitals at this point? Again, I encourage you to please feel free to chime in and ask some questions. Raise your hand, but we've also unmuted the line, so you're welcome to just speak up if you have a question that you're interested in asking. But ask a different question. So if the hospital is using the 2-cal HN oral nutrition supplement to increase energy and protein intake, is that going to be an effective way to meet the energy and protein requirements?
Well, Toolkit is an Abbott product, and there are similar products from other companies. But typically, it has 2 calories per milliliter, and usually these products have about 20 grams of protein per ounce can. So you're looking at about 475 calories and 20 grams of protein. And we've recommended for years as RDs and RDNs that you give 2 ounces of a product like this that's high nitrogen, high protein, calorie with mid-pass. And so that's going to give you about 120 calories and 5 grams of protein. That help meet energy requirements. That 5 grams of protein will not help with tissue synthesis. When we're looking at meeting our protein and energy requirements, I think we've done a better job with the energy, but we've stopped the protein through the day, and we're not giving 30 grams of protein at a meal or at a time, so that these mini meals aren't as effective in terms of triggering the tissue synthesis, but you're not getting high enough leucine dose to start the mTOR pathway. So using a mid-pass, using any of the high-calorie, high-nitrogen products is a increased energy requirements, but really doesn't help in terms of meeting protein requirements to optimize tissue synthesis. Now, it will provide some nitrogen, but it's not going to be the same effect as having 30 grams at a meal.
What the sugar-free collagen-based Oh, I'm sorry. Did somebody have a question? Okay, I was just wondering about those sugar-free collagen-based supplements.
Well, collagen-based supplements have a range of quality. Some of them are complete sources of protein. Some of them are not. Now, collagen naturally does not contain tryptophan, so it's not a complete source of protein. There are also some deficient amino acids in them as well. And so it's not the same as the gram protein from an egg, say. And the elixirs are very popular because in an ounce serving, they advertise you can get 15 grams of protein. So it may or may not be complete protein. If it's not complete, then you don't have all the amino acids you need for tissue synthesis. And is much lower in leucine than whey is and whole foods are. And so you're not going to be getting that as well. Now, collagen is very high in nitrogen. It does provide you with some calories. And so you could give 2 ounces, and even with the 2 ounces, you're still not getting 1.5 grams of leucine that you need to start the mTOR pathway. So again, you want to look at the quality of the protein products you're using if you are using protein supplements. See, if we're using whole foods, we know that we are getting a full complement of amino acids. The only caveat to that is that your ground meat products sometimes are not complete sources of protein because they're fillers or there's fat added or in them. And so sometimes those don't come up with amino acid score, a PDCAS score, 100%. But they're still going to be better than some of the protein supplements on the market that have a lot of significant limiting amino acids.
Right. So again, anybody who has questions, please feel free to chime in.
Or comments about things you'd like to change. What would you like to change in your unit that would optimize nutrition care?
Well, we can go back to the action plan and the ordering privileges. And I know that you suggested that, it's important to read those rules and regulations and then craft a plan. I'm wondering if you have any suggestions, especially for those hospitals who don't have those ordering privileges. And folks on the line, if you're one of those hospitals that don't have ordering privileges, are there specific questions, that you want to kind of tap Dr. Litchford for right now? What would be, the best way to approach trying to get those? And it's going to be an issue with the state that you live in. Any guidance from you, Dr. Litchford, on
you always have to look at your state licensure plan. If you have licensure for dietitian nutritionist, and those are different in each state. Some of the states are updating their licensure laws because they've been on the books for 20 years. Mm-hmm. 20 years ago, we weren't talking about ordering privileges for the RDN. So some of the states have worked with their lobbyists and their legislators to update the ordering privileges based on the CMS rule. And it is within the scope of practice. It's a delegated responsibility, and so the hospital can delegate that responsibility to you. In states, the speech therapist writes diet orders for consistency changes, and that is a delegated order as well. So you always want to be sure it is within your scope of practice. And if your scope of practice talks about nutrition assessment, we base our diet order on is the nutrition assessment. So keep that in mind as well. So that would be your first step. And then you always got to consider your culture in your hospital and the politics, and focus on, what's the purpose of the final rule, and that's to streamline things, to reduce barriers, and to reduce cost and have benefits for the patients. And so focus on those. What's it going to do for the patients, and what is it going to do for the hospital?
Cost savings come in.
Well, the cost savings come in just like with Jed. Jed went home on day 3, and we probably made a difference in his nutrition status in terms of prevention of pressure injuries if his diet had been changed on day 1. Jed made some other choices that weren't very good either, that increased his risk for skin breakdown. But so his nutrition status deteriorated the 3 days he was in the hospital. It did not improve. improve. And he went home not really knowing that he risked most likely and that he needed to do something different. And so patient education is very, very important. But you reduce costs for readmissions. The study that I cited, the year-long study in Australia, found that the full investment for the nutrition supplements for the individuals, because that's what was commonly used in Australia, was that when they provided more nutrition and more nutrition support, in other words, counseling, education, products to patients, that it was 87% cost effective. So that means it dramatically reduced the number of pressure injuries that they were seeing.
Right.
So that has proven to be very cost effective. And I think something that the American hospitals need to look at very closely if they don't have a plan in place at the moment.
Right. Well, I think we're going to have to conclude here, and I'm wondering if you can advance it all the way to the last slide, and note for those of you who are still on the line with us that there are some nice references listed at the end of the slide deck that you may want to take a look at some of these resources. With that, I just want to thank you again, Dr. Litchford. That was a great presentation. Loved going through that case study. And thank everyone else for attending. And just remind folks that we're going to be hearing from Washington and Broward next month. And if you mind completing the webinar evaluation, we would very much appreciate that. So with that, thank you again, Dr. Litchford.
You're welcome. Thank you for the invitation.
Right. And the meeting is adjourned. So everyone, have a good rest of the day.